Victoria, you're over there. Melissa, you're over there. Where's Jason? Jason, you're here. Oh, you're here. I heard him. He's got that soft, deep voice. Jason's on the computer. Okay. Madison. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So I'm missing one person. I'm not finding this other name. Madison, Wendy, Fumi, Victoria, Jason, Carolyn, Melissa, Joy, Anna, Roxanne. Whose name have I not called? Who?
Is Wendy there?
Whose name are you saying, Melissa? Sean and who else? Oh, Kalina. I'm sorry. So Kalina's out there? Hello? Hello? Okay, so she's not on here then, right? Okay, so Kalina, you don't see. I don't see Sean. I don't see, God, what's his name? Brooke. Victor. Are you out there, Victor? So I still have a name that I have. Somebody's on the phone with me then, because there's 11 people, not including me, on the phone or on the computer. Madison, Wendy, Fumi, Victoria, Jason, Roxanne, Anna, Joy, Melissa, and Carolyn. That's 10. So I've got one person. Oh, Jennifer. Okay. All right. So I'm going to go ahead and get started. I've got 11 people out here. I've sent the email out and we're going into a later time here. Okay. So maybe those who may be getting off work or something may be coming in a little sooner. So the first thing I want to do, can everybody see my screen?
Yes.
Okay. So can you see the pre-quiz now?
Yes.
Okay. So we're going to get started on the pre-quiz. And all right. You just start talking kind of like we do in class. I know this is a little odd, but we've got to try to get a lecture in here some kind of way. So the gastrointestinal pre-quiz questions. I know what I need. Does anybody have the page number of that? Oh Lord, the case study by chance? Which one it was? I have a bunch of them here, but I don't.
It's 51. Case study 51.
Okay, what page is it? What's the page number?
I'm not sure. It's 2 something. I'm not sure what the page is. But I printed it. I don't have a page on it. Then.
Okay.
All it says is case study 51. I'm going to have to go online to look at it.
Oh, sorry. I have it here somewhere. Thank you. Okay. All right. So, first question.
Hi, Rachel. This is Anna.
Anna, where are you, Anna? I hear you on the phone and on the computer. Are you on both?
Can you hear me on the microphone?
I hear somebody on the microphone. Who is that?
It's Wendy.
Okay, Wendy, I hear you perfect.
Yay, I'm logging off my phone then.
Okay, get off phone. I get it. Anna, if you're on the phone, if you're on the computer, hang up from the phone. Because are you on the computer with me? Can you hear me, Hello? Are you on the computer as well, on the phone, on the computer? Or just on the phone? Okay. Okay, well then hang up from this conference call then. All right, and make sure you can hear me over on the... Yep. I'm on both. I'm holding phone as well as join me. I got the speaker and the phone up to me. So I've got some people on the phone that can't get onto join me phone. Well, if you're on Join Me, you got to make sure that you've hit the button up there where it says phone, the little phone button. You see it up there? Okay, well, do that before you hang up. Yeah, because if you can download it and you have your microphone and your speaker, you have your earplugs and something to speak into the computer, then you can just be on the computer rather than just the phone. So you can do that while we're doing the clicker questions, and stay on the phone. Don't hang up until you can officially hear me on the other end. So Nurse Maureen is planning to teach a client with malabsorption syndrome about the necessity of following a low-fat diet. She develops a list of high-fat foods to avoid and includes which food items on the list?
Cream cheese.
Cream cheese.
Okay, good. And looks like some people are typing. That's fine if you want to do that. Whatever is good for you. Okay, great. Answer is fruits and vegetables tend to be lower in fat because they do not come from animal sources. Fish is also naturally lower in fat. Cream cheese is a high-fat food. Now, remember, when I'm doing my questions, words like malabsorption is going to be important to you. Malabsorption syndrome, okay? So kind of look at that. A lot of this, these questions just kind of similar to what we take on. The nurse is reviewing the physician's orders written for a male client to the hospital with acute pancreatitis. Which physician order should the nurse question if noted on the... Who is that just joined? I hear somebody just joined on the computer.
That's probably me.
Oh, hey, Brooke.
No.
Okay. Who's that just talking over here on the computer?
Roxanne.
Okay, so Roxanne, have you hung up from the phone?
Yeah.
Okay, good. You're great. All right. Hey, Brooke, welcome. We're not. No, it's gonna be hard. A lot of people couldn't download the Blackboard. So this one, you're on here, so you're able to get on here. But are you able to get on Join Me? Okay, go to the phone and press the phone button and see if you can get onto the computer phone. Connect to that. What is it telling you to do, Brooke? Okay, see if it'll let you start. Yeah, that means you're connected. Have you plugged in? Do you have a microphone? I mean, earphones and all that? If you want to, that's fine. Otherwise, you're on the phone. That's perfectly fine. Okay, so let's continue on. So the nurse is reviewing the physician's orders. Long as you can see the screen and everything, you can hear me. We're in good shape. I can hold the phone and the speaker thing to my ear. No big deal. The nurse is reviewing the physician orders written for a male client with acute pancreatitis. Which physician order should the nurse question if noted on the client's chart? I see somebody put, I think you typed it in as B. Do I see somebody just did B? Okay, and somebody put C. What are you all thinking?
B.
Okay, you're going with B. Anybody else?
B.
B.
B. Okay, anybody else? I see somebody else just typed in C. Okay. So the answer is C. Demerol rather than morphine sulfate is the medication of choice to treat pain because morphine sulfate can cause spasms in the sphincter of Oddi. Options A, B, and D are appropriate interventions for the client with acute pancreatitis. The nurse is monitoring a female.
Miss Schultz,
Yes.
you're echoing.
Yeah. I don't know why. I could tell that it's doing that. Maybe I'm too loud. I don't know. Can y'all hear me still? Okay, you guys are good on the phone. I'm echoing on the other side, and I don't know why I'm echoing. I'm sorry. Is that a little better? No, I'm still echoing.
It's okay. Just
We'll get through it. The nurse is monitoring a female client with a diagnosis of peptic ulcer. Which assessment finding would most likely indicate perforation of the ulcer?
D.
D.
Okay, anybody on the phone side want to comment? All right. The answer is perforation of an ulcer is a surgical emergency and is characterized by sudden, sharp, and tolerable severe pain beginning in the epigastric area and spreading over the abdomen, which becomes rigid and board-like. Nausea and vomiting may occur. Tachycardia may occur as hypovolemic shock develops. Numbness in the legs is not an associated finding. Looks like we lost somebody. Somebody had joined and now they're off.
Miss Shaw, can you increase the volume a little bit?
Hello? You hear me?
Mm-hmm.
Is that better, Joy, or somebody who's asking? Okay.
Well, that's better.
Okay, now with when you think about when you start thinking about perforation of an ulcer, we know that means that at some point that ulcer had closed up after surgery or whatever it is, or as it has healed, when it closed up, it had a lot of whatever inside of it, bacteria, blood, this, that, and other. Anytime that it has opened up, this is going to be, the pain is going to be very bad. It's going to be bleeding inside. It's going to be that rigid board-like abdomen. That's something that you want to recognize as a medical emergency. It needs to be taken care of right away. The nurse is caring for a hospitalized female client with diagnosis of ulcerative colitis. Which finding, if noted on assessment of the client, would the nurse report to the physician?
D.
Okay,
B as in
okay,
boy.
D. And did I hear C?
B.
Am I hearing C also? Oh, B, okay. Okay. Okay, got it. Okay, no. Okay. The answer is C. Rebound tenderness may indicate peritonitis. Bloody diarrhea is expected to occur in ulcerative colitis. Because of the blood loss, the client may be hypotensive and the hemoglobin level may be lower than normal. Signs of peritonitis must be reported to the physician. The nurse is reviewing the record of a female client with Crohn's disease. Which stool characteristics should the nurse expect to note documented in the client's record?
D.
Okay, I hear D. D as in dog. What else? Okay, I heard A. What else? Anybody else want to comment? Okay, I see C, B. Okay, the answer is A. Crohn's disease is characterized by non-bloody diarrhea of usually not more than 4 to 5 stools a day. Over time, the diarrhea episodes increase in frequency, duration, and severity. Option B, C, and D are characteristics are not characteristics of Crohn's disease. So we have to understand the difference between ulcerative colitis and Crohn's disease in order to be able to know how to answer the question. Now, when Crohn's disease gets really bad or get to the point where it's, very inflamed or whatever the circumstance may be, there's a possibility that it could definitely start having a little blood, but it's not as bad as what ulcerative colitis does. Okay, good. In care of a client with, let me see if I can move this. Okay, in care of a client with GERD, which task would be appropriate to assign to the nursing assistant?
C.
C.
As in cat.
C.
Are you saying D?
C.
Oh, C. Okay, we got C. All right. Okay. The answer is C, reminding the client to follow through on advice given by the nurses and appropriate tasks for the nursing assistant. The RN should take responsibility for teaching rationale, discussing strategies for treatment plan, and assessing the client's concerns. That the nurse assistant can reinforce certain things that are given by the RN. Otherwise, the initial things and teaching and planning and all that will come from the RN. You're providing postoperative care for a client who underwent laparoscopic cholecystectomy. What should be reported immediately to the physician?
B.
B as in boy. Okay. What else? Anything else? Anybody? Am I seeing C? I think people are putting in C. Answer C. Right upper quadrant pain is a sign of hemorrhage or bowel leak.
Ms. Schultz,
Yes.
I think the reason you might be echoing on the join me is that somebody's mic might be really loud, picking up you speaking through their speaker.
Okay. So anybody have their mic up too loud?
Or everyone could turn their mic off, and then to speak, they could turn it back up.
Okay. Now, as far as the people on the conference call, you guys are okay, all right? So don't do any muting on your end.
Hello, I'm lost now. Hello.
Why are you lost? I'm here.
My screen went away when I was doing the volume. I was trying to increase my volume and then my screen went off.
It might just have been minimized. If you look at the bottom of your screen, you might be able to click the join me icon and it should pop back up.
Okay, it's back now. Thank you.
Oh, goodness. Getting a little dry. Oh, Lord. Okay. I did want to tell everybody, I think only 8 students that paid for ATI so far. So your books, I do have your books. And those who are paying late, those books will come later. Okay, just needed to remember to say that. Excuse me for coughing. I'm trying to move the thing out my way before I start coughing. But anyway, you are providing postoperative care. Oh, okay. So the answer to this is actually C. Right upper quadrant pain is a sign of hemorrhage or bowel leak. Ability to void should return within 6 hours postoperatively. Right shoulder pain, the reason why they have the shoulder pain is the unabsorbed carbon dioxide, and it usually resolves by placing the client in Sims position. That's usually what happens when a patient, remember, when a patient's put under or whatever, they tend to retain some of that carbon dioxide, and it can go into dependent places over time. That's why we try to move and turn the patient and try to keep, try to help that move around and, be reabsorbed or whatever it needs to do or get out of the body. Okay, so that's why the shoulder pain is there. In this case, it would be a normal finding. GI or GERD weakness, lower esophageal sphincter, predisposing older persons to risk for impaired swallowing, and managing the symptoms associated with GERD. The nurse should assign the highest priority to which of the following interventions? You guys can type in your answer if you want to. Okay, a lot of people like
C.
Okay, small frequent meals or small frequent feedings require less release of the hydrochloric acid. Remaining in an upright position for 30 minutes after meals prevents reflux into the esophagus. Dysphagia is a cause of aspiration. Which of the following diseases would have the diagnosis risk for aspiration related to inability to swallow effectively? Select all that apply. And again, you can type in your chat, just type it in the chat, the answers you think they are. Okay, good. ABC. Stroke, especially in the midbrain and anterior cortical areas, is the most common cause of dysphagia in the older person. Parkinson's disease and Alzheimer's disease can cause dysphagia by inhibiting movements of the tongue, pharynx, or upper esophagus. Crohn's and ulcerative colitis affect the GI, mucosa, and submucosa and do not usually cause esophageal reflux or aspiration. Hold on one second. Okay, sorry about that. Does anybody happen to have Jennifer's number?
I think I do.
Yeah.
I have it. Do you want me to text her?
Yeah, if you text her or call her and tell her what we're trying to do. I just haven't been able to communicate with her. Lots of things going on apparently, but I want to try to get her part of this. We'll be through
Okay.
these in just a minute. Thank you.
I told her about the conference.
Oh, you did? Okay. And
Yes.
I've emailed her. I emailed her. Okay, no problem. Okay,
I told her to.
great. All right then. And I didn't hear that she was on the phone. Jennifer, are you there anywhere? No. Which of these agents is a major contributing factor in the promotion of peptic ulcer disorder? Okay. D is correct. Recurrence of peptic ulcers is related to the Helicobacter pylori, use of NSAID, smoking, and continued acid hypersecretion. Okay, so that's the end of that. Let's go into, I think what I'm going to have to do is I'm going to do the PowerPoints real quick. We are going to go through some of those tonight, something that I normally don't do since we've taken that away. But since we're doing it this way, we have an opportunity to get away with it. Give me 1 second.
Hello?
I'm here.
Oh, okay. I thought I'm lost.
Oh, you're not lost. You're not lost. Okay, turn up my mic. Okay. Can you hear me?
Yes.
Better? Okay. How's that? Is that better, worse?
Yeah, it's better. It's better for me.
Jennifer says
Go
she's
any
trying
higher?
to get in.
Who is?
Jennifer's trying to get in.
Okay, great. And I look like I've lost some more people. I don't know if people are accidentally getting logged out or what, but I hate to be losing anybody. Because this is going to be a really good one. I know it's kind of taking a while trying to get everybody on here. Blackboard was acting up. People couldn't get it to download. So I was losing more people on that Blackboard last time. So checking the emails. Okay, is that better? Can everybody hear me okay?
Yes.
Okay, good deal. All right, now I'm going to go in and I need to pull up something real quick. Okay. Are you seeing my screen?
No, I see
Are you
sharing
seeing-
post.
Oh, it's paused. Okay.
Yeah.
All right. Just give me a second. It'll come back up in a minute. Brooke? Brooke. Okay, I guess he's gone. Oh, you're here. Okay. I just didn't hear him talking. Okay. Oh, Lord have mercy. Course documents. Okay, I'm just trying to get a couple of things here real quick. Give me 1 second. All righty. All right, now I also have those concept maps. And when I hang up with all of you, I will email you all the concept maps for GI, GU, and diabetes. Y'all remember those from before?
Yes.
Okay, great. So I'm going to do that again, the same thing that I did. And what we're going to do today is acute pancreatitis, which is going to be case study number 51. And then when I'm done, I'll email this to you. And that's going to be page 229 if you have that particular one.
What about the clicker questions? Are you going to email the clicker questions too?
Oh, the
one we just
clicker
did.
questions, yes. I will email all
Okay.
of that.
Okay,
The pre
thank
and
you.
the post, okay?
Thank you.
Okay. So, and what you see, showing you one of the care maps right here. This one, diabetes. You see this one? Y'all see this one online? Okay, great. That's the ones that are going to, I'll be sending you all of that because we will have a little bit of diabetes here. It's not very much on diabetes, but I'll share because we don't have a lot. But it's got the diabetes education, that I'm going to tell that to you. It's just several of them right now. Okay. Did someone else just join us? Okay. So let's talk about the GI system. Or excuse me, case study acute pancreatitis, and then we'll go into the case studies because I'm going to have to, you know how I do, I have to talk really fast going from there. Okay, y'all ready? BK is a 60 admitted to the medical surgical unit from the emergency department with nausea and vomiting, and epigastric and left upper quadrant pain, abdominal pain that is severe, sharp, and boring and radiates through to her mid-back. The pain started 24 hours ago and awoke her in the middle of the night. BK is a divorced, retired sales manager. Is somebody on? Who just got on?
It might be me.
Okay, so you've hung up from the
Yeah.
phone? Okay,
Yeah.
all right, no problem. Who smokes a half a pack of cigarettes daily. The ED nurse reports that BK is anxious and demanding. BK denies using alcohol. Her vital signs are as follows: 100 over 70, 97, 30, 100.2, tympanic. SATs are 88% on room air and 92% on 2 liters of oxygen by nasal cannula. She is in normal sinus rhythm. She would be admitted to the hospitalist service. She has no primary care provider and hasn't seen a physician in years. The ED nurse giving you the report states that the acute pancreatitis of unknown etiology. A CT scan has been ordered, but unfortunately the CT scanner is down and won't be fixed until morning. However, an ultrasound of the abdomen was performed and no cholestasis, gallbladder wall thickening, or cholecystitis was seen. The pancreas was not well visualized due to overlying bowel gas. Emission labs have been drawn. A clean catch urine specimen was sent to the lab and the urine was dark in color. What is the possible causes of her pancreatitis?
Infection? Not infection.
Okay. Infection.
Certain drugs, corticosteroids, thiazide.
That's right. Corticosteroids, that's correct. What else?
And the smoke cause it.
Yes. Now she smokes half a pack a day. Smoke could be related. What other things?
Viral infections or trauma to the abdomen.
That is correct. Okay. What else?
Metabolic disorders or vascular diseases.
Okay, that is correct. What about a biliary tract disease, something going on with the liver, a blockage or obstruction? Okay, what about excessive alcohol use? You said trauma. What about a pancreatic obstruction? What about hyperlipidemia and penetrating duodenal or gastric ulcers? You said earlier certain drugs. A lot of times when drugs are elevated in the blood, it can cause a toxic, can be too high, too toxic, and can cause problems with the pancreas as well. Some of these can be that can cause this can be your oral contraceptives, opiates, sulfonamides, the thiazides, like she said earlier, and your corticosteroids or steroids. Good job. Good. If a CT scan is planned for the morning, what orders would you expect? What would we want? What kind of orders would you expect to see on this client that's having acute pancreatitis? What I want to know.
NPO status.
What do I, okay, yes, NPO for at least 4 hours before the test. Good. And, you know, sometimes with this CT scan, I'm probably going to do an oral contrast. It just depends. And especially the fact that they couldn't visualize it when they did the sono, they may do an oral contrast. Great. What else? And this is where you obviously need an IV access, because if you're using some kind of contrast dye and so on and so forth, you need to make sure you document what?
Input and output.
Okay, but what do you want to document before you give her any of these dyes or contrast?
Allergies.
Allergies to what specifically? If you guys want to type, you can. I'm looking up there. Okay, I see allergies, yes. And what else? Allergies specifically to what?
To the dye.
To the dye, the iodinated dye or iodine, very, very important to know. And we also need to consider the shellfish. Shellfish is one of those. Okay, good. I see your responses up there as well, the contrast dye. Okay, all right. What is something else do you think I'm probably going to want to know about this patient? What other organs are going to be?
Did they give her any pain meds in the emergency department?
You can ask that when you're getting this patient checked in. You would like to know, but now this is going to be the CT scan for the morning. What other labs would you want to be concerned about, and what organ would you want to be concerned about when you have this acute pancreatitis?
Kidneys.
Oh yeah, you need to be concerned about the kidneys. So would you want to know what her chemistries look like? Somebody typed in kidney, and it doesn't. They're BUN, creatinine, good. Liver is good in the sense of the fact that if it is definitely an obstruction, the liver is going to be important. But you guys are definitely right on it. And I don't know who you are that's responding, because all it shows on my side is viewer 2, viewer 6. So whoever's answering those things, you're doing good. But I am looking at that and trying to listen to you guys as well. Yes, so I want to know about the BUN and creatinine. I want to know all about her, her albumin. I also want to know what about her potassium, her sodium, and all those things, because the kidneys have such a large function in the body. And this is important to understand when you're dealing with the pancreas having its problems, because then these other organs in the body can be infected, kidneys being one of the larger ones. And the thing is, what's one of those things that can affect the kidneys big time? And this is why we really want to make sure we know that the kidneys are functioning normally. What's the things that you're doing to this patient that can cause some major problems to the kidneys? The dye. That's right. The dye. Whoever viewer 15 is, good job. Yes, the dye, the contrast dye. That's why we need to make sure we're trying to get a baseline. Are her kidneys functioning normally? Because you're putting all this dye in here that can cause the kidneys to fail. What other information do you need from the ED nurse before you assume responsibilities for the patient? Wendy, you stated earlier, pain medication. This is a report. You're about to assume the care of this patient. What all do you want to know about this patient? Labs. Okay, what labs were drawn there? Okay, what's one of those things? Yeah, what are those vital signs? What IV fluids? Good. what are those things that you got to think about when this patient is down there? We're talking about the pancreas. What would alert you? What would you start thinking about when you think about that pancreas? Her diet, okay. Mm-hmm. Glucose. I would definitely like to know, what is your glucose? I don't know who this is typing, but y'all are rolling. I appreciate that. But when you think about her glucose, are we starting to think, wait a minute, this is the pancreas with something? Okay, Brooke, you go, Brooke. Okay, good deal. You start thinking about this glucose, and well, it's also, yeah, is the glucose too high or too low? Those are concerns because we're thinking about diabetes, right? Does that kind of click in your brain because you think diabetes, pancreas, all that's involved there? So good. Let's see. Yeah, what was the glucose level? Because if it's too high, then we're probably concerned. Yeah, we're thinking about was insulin given? Did insulin have to be given? Good. You start thinking about, if it was too high, could the pancreas be shutting down, or there's some other issues going on? Also, we've already obtained her allergies. What else is important to find out about this patient? She's a 63-year-old patient. Somebody said INO status earlier. That falls in this area. Does a complete assessment need to occur here? History. Okay, you put it up before I got a chance. Good job. Yeah, okay, great. Somebody already put up there about the history. The other thing is, yes, what about the surgeries? Any other problems as far as her history, starting from head to toe, usually, especially a 63-year-old patient who's being admitted and has all these problems. So yes, you want to get that SBAR, situation, background, assessment, and recommendation. And you also need to find out if she has any, yes, do you have any surgeries? You also want to find out if she has any family members who can be called. Okay. What are the lab orders for the next day? Yes. What medications is she taking? Great. You guys are doing an awesome job on that. This here is across the board. Pretty much every case study is pretty much going to ask the same kind of questions, because you have to do that complete history and physical. And all of this stuff is going to come together. I know you're thinking, oh my God. And of course, I'm not standing right in front of you doing this, but this is why I have to try to include everything we would do if we were actually in lecture. Now, lecture, when we come back together, you know, you just have to be prepared with your PowerPoints, because again, we're not presenting PowerPoints in the classroom. I'm just going to do it here now, because the GI is the bigger lecture. Yes, I see where you said, are there any blood thinners that she's taking at home, or any types of medication that can cause her to start hemorrhaging, especially? Hello?
Sorry.
Okay. Everything okay?
Yeah.
Put me on mute for right now. Okay, good. All right, because I think we started echoing again. Okay, you complete your admission assessment and note the following abnormalities. BK is restless and lying on her right side in a semi-fetal position. Cerebral vascular findings are skin is cool, diaphoretic, and pale with poor skin turgor. Mucous membranes are dry. Heart rate is regular but tachycardic without murmurs or rubs. Peripheral pulses are faintly palpable in 4 extremities. Respirations are rapid but unlabored on 2 liters of oxygen by nasal cannula with a SAT of 90%. Already concerning to me is all the things they've just started to say about this patient. What are some things you think is about to happen or is happening to this patient right now, just based on those findings? I'm sorry. Well, I hope not. I hope we're not to the dying part. That was good. God forbid. But what's happening, we're going to head that way. Yeah, she's going into shock. This patient's going into shock. And look at those SAT levels. They're pretty bad. Breath sounds are absent in the lower lobe. Okay, posteriorly. Otherwise, clear to auscultation throughout. Now, this thinking about the fact that she smokes and that she's 63 years old. We don't know what kind of collapse she has going on, and she's beginning to get pale, and her SATs are not looking good. She complains of nausea and is having dry heaves. So she's, got that little gag like, I'm about to, dehydration is absolutely is happening here for sure. She's having this dry heaves. That's something to be afraid of. Did Jennifer join us? Bowel sounds are hypoactive, very hypoactive. Boy, I just hate that. I don't know where. Okay, nobody's emailing me, so well. She complains of nausea and is having dry heaves. Bowel sounds are hypoactive. Abdomen is distended, firmed, and tender in diffuse fashion to light palpation with guarding noted. So this patient is in pain as well. Admission lab test results: lipase 3,000, amylase 2,000, alk phos 350. You should have this on your actual case study. Are y'all able to see the case study? Are y'all looking at the case study with me or just listening to me right now?
I have it with me.
Somebody, I'm hearing, you might want to put yourself on mute. I hear water or who's on the phone? Okay, Joy, you still there? Who else is on the phone? Oh, you're fine. I just want to make sure that I still got somebody on the phone. You're fine. You're fine. Okay. Which specific lab results point to the diagnosis of pancreatitis? Okay, the lipase was 3,000. The amylase was 2,000. Alk phos is 350. ALT is 90. Okay. AST is 150. Total bili is 2. Albumin is 3. BUN is 24. Creatinine is 1.4. White blood count is 17.5. Okay, good. So lipase and amylase levels are extremely high. In addition, what else is going wrong here? What other things are wrong here? Not quite on this one. Yeah, but what other labs that I just named are things that you want to be concerned about here? Okay, you got, okay, the white count. So we're worried about sepsis because I think Victoria said earlier, we're thinking about infection could cause problems. What about the liver enzymes? They're elevated here. Okay, and then the low albumin levels might be decreased with inflammation, stress, or liver disease. Okay, the elevated white blood count might also reflect inflammation and infection. Which labs are the most important to monitor in acute pancreatitis? You all already named it as amylase and lipase. The pancreas is both an exocrine and an endocrine gland. It has the two functions. The exocrine part consists of secretory units called pancreatic acini that produce and secrete encapsulated lipase and amylase through the pancreas ducts into the CBD. These time, I can't even see, sorry y'all. These time release capsules travel into the duodenum through the sphincter of Oddi. Total time self-destruction is about 12 hours. Okay, mainly that you want to understand that when you're dealing with acute pancreatitis, your amylase and lipase are going to be those two labs that are going to be off. What do the BUN and creatinine tell you about her renal function and volume status? What happens? Okay, so what happens with dehydration? What happens with the BUN? The BUN does what? What happens to the BUN when there's dehydration when she's dehydrated? It goes up. And what does it have? What happens when in fluid overload? It decreases in fluid overload. Okay, the creatinine reflects the filtration of function of the kidneys and their ability to handle fluid challenge. BK's BUN and creatinine are both elevated, which might reflect dehydration. Usually the way I look at the BUN and creatinine as well as a sodium level, high, you're dry. Okay, that means you're dehydrated. If you see elevated BUNs, elevated creatinine, elevated sodium, high, you're dry. Okay, low, you're overloaded. Okay, that's one way to kind of remember that. And then when we think about the WBCs, we have to consider that the WBCs may represent something is inflamed. It could also represent an infectious process. She definitely needs to be monitored for both. Remember, her abdomen was rigid and painful, and she was guarding. During your physical examination, you noted respirations rapid but unlabored on 2 liters of oxygen by nasal cannula with SATs of 90%. Breath sounds are absent in the lower left lobes posteriorly, otherwise clear to auscultation throughout the admission. Chest X-ray reports small pleural effusions in the left lower lobes. Let's see. Okay, so how are we going to help her respiratory status? What's some things? Yeah, I'm concerned about, pneumonia and things like that. True. What is some of the things that we can do to help correct her problem? Okay, good. Good. Coughing and deep breathing. Absolutely. Okay, if she's definitely in fluid overload, then we may consider Lasix. I think she's actually dealing with some dehydration on her end right here. What's some other things? Okay, what else would we do? We're gonna do fluids. What else can we do to help her respiratory problem? She could be third spacing. Nope. In this case, we're not going to ambulate this patient, right? She's already on her oxygen, the amount that she needs. So she has the oxygen, but what's some things we can do in addition? Okay, put her in the semi-Fowlers, raise the head of the bed. Would we want to use some pillows to help when she's coughing, to use as a splint when she's coughing, because sometimes that's causing more pain. We want to continue to reevaluate her, making sure that her pain is under control. Okay, as well as watching her respiratory function. Good. BK turns on her call light. She complains of thirst and demands something to drink. Her orders indicate NPO except fluids and chips. What is your response to her request? What nursing action would help her complaints? Okay, we may give her a few ice chips, but what happens when you give, if you're supposed to be NPO and you're in acute pancreatic stage problems, you're having problems with acute pancreatitis, what could happen if you give her fluids and things? It can make it worse. What it does, oral intake can stimulate pancreatic function and thus increase her pain and nausea and vomiting. So this is why we're trying to continue to watch her pancreatic enzymes, the inflammatory response, trying to see if we can get that back under control. Okay, and I see glycerin swabs. Are you talking about those little oral swab things, the sweet tooth type things? Is that what you're talking about? Okay. Yes, absolutely. You can do that where she can kind of clean out her mouth and it kind of gives it a little, it basically causes her to use her own saliva to help her. Yeah, good. How often or what drawn? Oh, the labs. It just depends. Labs, in the case of that, they probably drew these labs probably every morning. They're probably checking these labs. The only time that you'll see them taking serial labs is labs like hematocrits, things that they can check every few hours if a person has gotten blood or things like that. But as far as her enzymes are concerned, usually they want to wait 24 hours. Okay, is that what you're talking about? Cardiac. Okay, what's the question about cardiac? Okay. Okay. All right. Okay. Now BK eventually falls. Okay, eventually falls asleep and seems to be sleeping peacefully. Several hours later, you hear an alarm on her pulse oximeter and enter her room to investigate. You find BK moaning softly. Her oximeter reads 87%. What will you do next? Okay, check the placement of the probe. Okay, I see. Hopefully she's already, hopefully she's already got her head of bed raised. But make sure that the tubing, the oxygen tubing and everything is still connected properly and inserted in her nares. What else? Okay, yeah, okay, y'all are answering. Yeah, assess. So you're assessing. What else are you going to assess? Okay, so right here, we probably won't be concerned about the edema and the sugar right now. We're still talking about her respiratory status at the moment. So wouldn't you want to check her level of consciousness? Yes, listen to her breath sounds. Check her level of consciousness if she's coherent to make sure that, she hasn't had that she's actually started trying to slip away or anything like that. So yes, look at her, check the tubing, all that good stuff. Y'all are definitely on the right path on there. Your assessment findings are as follows: lung sounds absence in the lower lobes, very diminished in the right. You percuss a dull thud over the left middle lobe, and so on and so forth. What is the significance of your findings of having absent breath sounds at this point? What do we think may be building up here? Yeah, you're checking for crackles. Great. What do you think is happening here? Yep, there's a buildup of fluid, a pleural effusion, consolidation, pneumonia, pulmonary edema, lung abscess. Absolutely. Okay, what action should you take next? Now, what can you do right here? Okay, before we do that, we're sitting in the room, or we're in the room. You've raised the head of the bed, but what can you do right here for this patient? Now this is definitely something where you can, because her SATs have dropped. Her O2 SATs dropped. What are we going to do here? Increase the O2. As you're doing that, yes, call the doctor. Assess the vital signs. Should you leave the patient? Okay, woo. Well, those nose went crazy there for a second. Okay. All right, good. Stay with this patient. Continue to monitor her. Be prepared for CPR. Make sure your bag and mask is ready to go because you may have to be bagging this patient. This patient is probably declining on you. Physician orders a stat chest x-ray, and it shows a significant pleural effusion developing in the left lower lobes with extension into the right lower lobes. Based on the involving pleural effusion, with there evidence of decomposition or hypoxia by the patient, what treatment would a physician likely pursue, and what preparations would you be responsible for? Yes, getting that fluid off there, pleural fluid, getting the thoracentesis going. Okay, consent and all this stuff has to be obtained. You basically are going to be responsible making sure that you get all of the equipment in place. You're also going to make sure you have the bag and mask, everything ready to go. Making sure that you have all of the dressing stuff, that because you're going to have to put a sterile dressing. Good job. Whoever number one is, good job. Okay. The physician removed 200 mils of slightly cloudy serous fluid. Antibiotics were adjusted to provide broad spectrum coverage for an upper respiratory tract infection until culture and sensitivity results return. BK is resting quietly with oxygen of 3 liters per nasal cannula, and her respirations are unlabored and regular. Her SATs up to 96%. It is now 72 hours after BK's admission, and her labs show improvement. An abdominal CT scan is completed and shows moderately severe pancreatitis, but no local fluid collection or pseudocytes. No ileus or evidence of neoplasm. was noted. BUN is 9 and creatinine is 1. She has adequate urinary output. Her IV fluids are decreased, 75 mLs per hour. Her amylase and lipase levels are decreasing toward normal levels. The physician writes an order to advance BK's diet to full liquids. How would you know whether BK was not able to tolerate advancement in diet? Yeah, good. Her pain would increase, nausea and vomiting and all that. And then there would be an elevation in amylase, lipase, and the white count could also occur. Good. If BK does not tolerate advancement in diet, what physiologic need should be addressed at 72 hours? God, that's beautiful. Beautiful. That nutrition, BK likely needs TPN. Good. Good. Delivered through a centrally placed line or a feeding tube placed beyond the ligaments of triads to avoid stimulating the pancreas. Great job. Okay, I'm going to finish that up and we're going to go on to our case studies. Y'all hang in there with me. We'll be through with this in a minute. That seemed like a lot, but I'm going to go through these kind of fast. Okay, the assessment of the GI system, you know, we always go back to our anatomy and physiology, exactly, you know, what stimulates, what is the GI responsible for? When we think about the GI, where does the GI start? It's gastrointestinal, beginning from where to where?
Mouth of the
Mouth, anus. Good. Okay. Then you start talking about the blood flow and so on and so forth, and then the structure and all that of the GI tract. You know, I'm not going to go through all that. And then the stomach, the pancreas, the liver, and gallbladder. We know what it all includes. This is all going off into strictly your anatomy and physiology. Just remember, when you're assessing this, everything becomes important. You have to think about the history and physical. What are some of the family history? Is some of this stuff passing down from generation to generation? Is it hereditary? What's going on? You need to know the norms on your labs, most important labs when it comes to the GI tract. Okay, and there's many of them there. This here is I'm not going to try to say it, but this here you want to think about when you look at that being done and that's going down into a patient's mouth. What would you, that's the EGD, correct. What would I be concerned about once this procedure is completed?
gag reflux.
Yeah, we want to make sure that the gag reflex is returned. Good job. Okay, good job. Okay, and this is talking about the upper GI, the small bowel, and things like that. These are those patients before the test. What do you need to teach the patient? You also want to tell the patient about what's going to take place, what we're going to have them doing. They're going to be drinking the barium. Remember, allergies are always important. Another thing is, you know, letting them know you'll be sedated some, just so that it won't be uncomfortable for you. Also the purpose of the procedure. Why are we doing these procedures? Okay. And a lot of these you'll see coming back as you start looking at the different things that go on with the GI system. Of course, now we want to try to, once these series are done, we need to give plenty of fluids. Why? Because we want to do what?
Flush.
What are we trying to do when after these procedures are done, we increase the fluids? We're trying to get rid of what?
The barium.
The barium.
Yeah, get that barium out. So that's usually what we want to do, and we want to get it out of there soon because we don't want that barium to get all chalky in there. Okay, and usually they'll do sonos and stuff like that to go back and look at. Okay, just all of your diagnostic type tests that you need to go back and look at, colonoscopy. And basically making sure you understand what to do and how to teach the patient to be prepared for that. Okay. We did the pre-quiz questions first. Yeah. Okay, and then we do clickers later. Okay, so when we start looking at the problems with the biliary system, pancreas, and liver. acute cholecystitis. Acute cholecystitis, the inflammation of the gallbladder. So we know that it's inflamed. So we start thinking about what is our problem. Things that we need to think about are our gallstones. What has occurred? A lot of patients with gallstones start having that kind of pain, gaggy pain, and sometimes when they're throwing up green bile and things of that nature. A lot of times you'll find that we have to put down an NG tube to get that extra bile and stuff off of the stomach. But with this, you have a lot of patients. A lot of this is concerned. Here they are right here. A lot of it is diet. Diet has a lot to do with this. You have a lot of patients at some point they end up having to have their gallbladders removed. You have a lot of people walking around without their gallbladders. Many of them have to end up changing their diet as a result. This person with chronic cholecystitis, this is a patient at some point will start looking jaundice to you. And the reason why they're having the jaundice is because of obstruction. All right. And what happens is those impurities from that is gotten into the blood. And in order for it to get out, it starts going out through the skin. You can see the jaundice looking color coming through the skin. And that's when they have the pruritus, which causes the itching. Well, at some point, this is going to get really bad. It's going to build up in the blood. And of course, it's going to go to the brain and cause connectors and kill the patient. So this is why it's so important to get this, if they have gallbladder disease, or the gallbladder is obstructed, this can be a serious situation and the patient could die as a result of this. So, clinical manifestations, this pretty much gives you what it looks like, or when the patient has problems with the gallbladder, chronic gallbladder. Excuse me one second. Okay. Okay. The goal is nutrition therapy, low-fat diets, fat-soluble vitamins, bile salts. Drugs are going to be your pain medication, of course, morphine, and so on and so forth. And they have the lithotripsy that they go in to try to break up these gallstones and so that they can get rid of them, and maybe they can pass through without any problem, and the patient end up not having the gallbladder removed. If the patient has to have it removed, then usually these are patients who end up, out 2 or 3 weeks or so, and they can come back to work. Not usually for gallbladder removal, they're not out very long, but teaching is going to be very important. Okay. Acute pancreatitis, we just talked about that. Acute pancreatitis is a serious and possibly life-threatening inflammatory process of the pancreas. This here, patients feel really sick when they first come in with this. And sometimes when they come in with pancreatitis, they don't even realize that's what they've had over a period of time. They actually are complaining about everything else, and then realize when they come in the hospital they've lost all this weight. I can say, for example, my uncle, he had no idea that that's what he was suffering from. He just thought that everything he was eating was just going bad, but he was losing all this weight. Finally, he got so sick, he came into the hospital, and he was at this point like, help me. And we were really worried about him for a minute, but thankfully they were able to determine that it was acute pancreatitis, made him NPO to give the pancreas time to rest. Gave him his nutrition through the fluids, and as he got better, they started to put him on food and see if he could tolerate it better, and then that he would be able to go back to full feeds. And this here gives you a nice little chart that kind of talk about it a little bit more. Complications of acute pancreatitis, we pretty much talked about a lot of that, and it was on the PowerPoint. Hypovolemia, hemorrhage, acute renal failure, paralytic ileus, and this is where basically the bowels block up. Hypovolemic shock or septic shock can be really, really bad. Okay, this is just going on. Remember, we talked about diabetes there. One of those things, the first thing we think about, and of course my uncle is diabetic, so he's one of those things we have to think about with diabetes. Diabetes affects everything. Somebody has diabetes, it can affect any organ in the body because it's microvascular and the macrovascular systems. It can just destroy it. That's why they from high blood pressure and all these other things. Okay. These are other clinical manifestations. Here's your lab tests, some of the ones that we just went through. The pain, what happens, what do you do? Interventions include priority for the patient care to provide supportive care and relieving symptoms, so on and so forth. Non-surgical, this is when we do the fasting or taking them off of food, let them rest, let the the pancreas rest. Okay, these are the surgical management, and this is when you might have the took place and so on and so forth. Again, NPO is going to be very important. Okay, this is going to go. I'm sorry, I went too fast. Previous. Imbalanced nutrition, less than body requirements. This is one of your nursing diagnoses. What do you do? Interventions in PO early stages, antiemetics because they're nauseated. As they begin to tolerate meals, you want to have them small, more frequent, low-fat meals, and monitor them to see how they tolerate these foods. If the GI system or the pancreatic system begins to get overly stimulated, then it can cause them to be sick again, increasing their labs and everything. This talks about chronic pancreatitis. You want to look at this is a person that deals with this on a constant basis. They have episodes and problems. You can read through that. Hepatitis, widespread viral inflammation of the liver cells, hepatitis A through E. And you want to go through there and pretty much just kind of remind yourself, refresh your memory on what each one of those are. But we know that that's an inflammation of the liver. If the liver is inflamed at any time, it can cause bowel obstruction, or there could be an obstruction, can lead to jaundice. It can end up taking the patient out as well. When there's a liver obstruction, then that can lead to bowel obstruction as well as pancreatic obstruction. And at some point, you'll start seeing that buildup of jaundice in the bloodstream, the pruritus, and so on and so forth. Okay, let's talk about each one of these, hepatitis E, and you can go back and look at it, looking as well as the clinical manifestations, okay, of what happens with these different type of hepatitis. Okay. Probably going on fast. I apologize. I'm just trying to get you guys off of here. Not so much for myself, but for you guys, because I know you're tired. And I'm tired too. Y'all doing okay? All of you that are hanging in there. And then once we get through with this, then I'm going to go through a few GI notes. I want to look at the terms real quick and try to get through our clicker questions to see if we're kind of saying on the same page. Okay. A lot of these, like I said, are really short. Okay, patients with esophageal problems. This is your GERD. GERD results as a result of backward flow or reflux into the GI contents back into the esophagus. These are those patients, especially these patients who have, okay, I see yes and yep. Thank you guys. Hang in there with me. We're going to be through with this shortly. With these patients, and I'm kind of probably going so ahead of myself, I apologize, because some of this you just start summarizing at some point. Think about when you have GERD and you have acid going back on something. What do you think it begins to do to that esophagus? Yeah, break it down. It begins to erode. Exactly. And at some point, that erosion is going to become even worse, where it's going to become inflamed. It can get infected. And how many times, if you think about something that's all eroded and that's all tender, do you think people are going to want to eat? Most of the time, they're not going to want to eat. They're going to, do a lot of throwing up, because it's like it burns every time they eat something. So they avoid it. You'll even find them chewing on the food and spitting it out, just swallowing some of the fluid but spitting out the actual solids, because it's so bad. It just hurts so bad trying to eat it. So these are those patients where we start talking about our drugs, your proton pump inhibitors, Prevacid, Protonix, Prilosec, Nexium, your purple pill. Those are when you start seeing these patients who have to be on these drugs long term, because they have such problems with acid and this reflux, and it's supposed to help with that. You also have those patients on the H2 antagonist drugs. Do you remember what those are? H2 antagonist drugs.
Plavix. Protonix.
No, Protonix, Nexium, and all of them are going to be in your family of proton pump inhibitors. But naming some of those H2 antagonists out there, drugs. Okay, Pepcid. What's another one? What's a good? Zantac is another one. Those are one of the two that are highly especially when there's just like an acute episode, they'll take that and say, okay, that feels better. But people who have this gastric reflux disease on a long-term basis, or and it's not resolved with just an antacid type pill or on your Zantac drug. Tagamet is another one. Then these patients end up having to have correct. They have to have surgery to correct it, because what happens that sphincter, the esophageal sphincter, begins to lose its tone, its strength, what its responsibilities are, and then it just kind of gives out. And sometimes they have to go in and correct that. But these again are going to be those patients who are going to be on that those drugs for a longer period of time. So dyspepsia, of course, we got the regurgitation. Yeah, that's true. Make sure they're not on Fosamax. Who is that again? That's Mr. Brook. Okay, yeah. Regurgitation, eructation, flatulence, hypersalivation, or water breath. What is the dysphagia? Remember when I told you they're chewing on the food sometimes, and they'll just chew on the food, but because it hurts to swallow or they're so worried to throw up, they'll end up swallowing just the juice and just spit out the food. Okay, so those are some of your clinical manifestations. Excuse me. Diagnostic assessment, 24-hour ambulatory pH monitoring. This is something that they'll watch in the hospital. They can have the EG done, and esophageal manometry. These are just other diagnostic tools that can be used to check the GERD. Non-surgical, of course, we take care of the nutrition side of it. Try to avoid those foods that cause more of the reflux. It causes a lot of the buildup of the acid. Lifestyle changes, making sure that the head of the bed is up. Sometimes these are those patients who have to put blocks under their head of their bed to elevate it. So they may apply blocks or bricks or some kind of something to raise it up to help them. Yeah, whoever number 6 is. Yeah, avoid milk. Milk can cause an increase of mucus. Yeah, that is true. Before bed, but drinking milk is good otherwise when you're awake and round about, giving it opportunity to digest. But patient education is going to be very, very important. But you'll see them sometimes put blocks, and that's something good to know. Antacids elevate the level of the gastric contents, and these are your H2 receptor antagonists. Those are your decrease the acid production. Proton pump inhibitors provide effective long-acting inhibition of gastric acid secretion. So those are the ones that are on that for a long time. The procainic drugs increase gastric emptying, improve lower esophageal sphincter pressure, and esophageal peristalsis. And that's stuff like your Reglan. You give them the Reglan, and the Reglan, increases gastric emptying, make it a little bit easier for it to get out of the body. Okay, so other treatments, endoscopy therapies, and of course surgical therapies. Hiatal hernia, protrusion of the stomach through the esophageal hiatus of the diaphragm into the chest. This here we don't do a whole lot talking about, but do go back and review that, because I'm not sure if that question will be brought back into this test or not, or if it will be more of on ATI or HESI. Okay. Okay, and it just kind of gives you a picture of the herniated portion of the stomach right here. Okay, assessment is showing you this. And a lot of times this one gets confused with, they might think that they have GERD here. So it can get misdiagnosed in some cases. This is just management for that. I'm gonna go away from these here. I'm not gonna talk about, because I don't really want you to focus on those right now. Okay. Okay, I'm gonna go here. Care of the patient with stomach disorders, gastritis. Y'all probably remember this from second level when we talked about this. I don't want to get off into the type A, type B, and atrophic. Basically, just need to understand the gastritis part. And one of your biggest problems is your Helicobacter pylori, and this is also in your ulcers. Okay, this is that one that's the bigger causative, and this one also, E. coli, can cause gastritis. And basically, it's just a gastric mucosa, as it gives it in the word. It's the inflamed um, inside of the stomach, or the gastrite. That's where the gastritis, inflammation of the gastric mucosa, which is inside the stomach. These are your clinical manifestations. Feel a little bloated. A lot of times we'll call gastritis, after we've had a bad meal or something like that. We'll say, oh, I got gastritis, and you feel a little abdominal tenderness, bloating, feel like that you need to use the restroom. But we kind of get that word mixed up. And, a lot of times it's just a little, food poisoning or something like that, God forbid. But when you start having blood when you're vomiting, or blood in the stool and things like that, you need to really be concerned, because there's a breakdown of that mucosa, which can become ulcerated and can cause you to be having some bleeding internally, which at some point can place you into hemorrhagic shock, or bleeding in places, in the within the stomach, and that's at that point the stomach can become really rigid. They go in and you'll start throwing up blood or pooping blood, and they'll start thinking, what's going on, because that is ulcerated. It has eaten into the mucosa so bad it can lead to this. Something that you would want to get checked out, and hopefully you're not there a long time having this problem and haven't gotten it checked out. So usually with these are your drugs that they'll start giving you: antacids, your H2 antagonists, and Carafate is one of your mucosal barrier fortifiers. I really don't know if they're still using it, but they're still teaching it in our books right now. I haven't seen that drug in a very long time, but Carafate is one of your real big, beautiful pink pills. When you look at it, it looks like a piece of candy. Just don't go around eating that, okay? But anywho, that is your one of the drugs that are used for gastritis. Another thing is, because it affects vitamin absorption, you will see patients who are having to be on B12 shots or medication. Other therapies, of course, they'll be talking to you about limiting foods on your diet. Stress reduction. Stress brings out everything, right? And they'll talk about surgical management. Here's your peptic ulcers. Once there's a breakdown in the mucosal barrier, then you don't have nothing to protect the lining of your stomach. And every time you eat something, it's going to irritate the stomach. At this point, this is when, if it's not controlled, and this is your other friend that comes back again, Helicobacter pylori, which is bad for PUD. So when it becomes that bad and it starts bleeding out again, this is when you start concerning yourself for hemorrhage and everything of that nature. So you look here, it's kind of showing you the ulcer formation, just a kind of visual there. If you want to look at that. Here's another one here. You see this here, the gastric ulcer here, and the duodenal ulcers. Those can become really bad over time. And every time you're placing food and things like that, that can actually irritate that, the sicker the patient can become. And it can become widespread. Okay, there's duodenal ulcers, talking about pretty much the same thing. Stress ulcers, complications of ulcers, telling you about it, the hemorrhage and perforation and all that. If you know that a patient has perforated, this is that stomach that becomes board-like and rigid. This is something that's a surgical emergency. You need to go back in surgery. Okay, you got your GI bleeds, clinical manifestations. Again, this is going to be that epigastric tenderness, because there's bleeding going on there. This is something that, the patient just feels full, and they can actually see some of the distension and guarding because of the pain. You have acute and chronic. Talks about your drug therapy, and there is your treatment for this, which is your proton pump inhibitors. We're going to have our Flagyl and tetracycline. Flagyl is the metronidazole. That's a type of antifungal antibiotic. Clarithromycin and amoxicillin, Dioxin and amoxicillin, both other antibiotics to help with this particular problem with ulcers. There's your proton pump inhibitors. I think I named some of those earlier. Your H2 H2 antagonists or H2 receptor antagonists. There they are, and you listed them earlier. Axet was removed from the market. You probably see drugs like Tagamet there a little bit more often. Okay, and then you have your prostaglandin drugs. Oh, okay. Antacids. Y'all know about your Malox and Mylantas, right? All right. And then you have your Carafate. These are drugs that if I were you, I would be looking those up to make sure I understand those things about those drugs. Okay. Nutrition therapy may be directed towards neutralizing acid and reducing the hypermotility. A bland, non-irritating diet is recommended during the acute symptomatic phase. This, we try to encourage them to avoid that midnight snack or that late night snack. Of course, your alcohol and tobacco. And then, of course, you've got your exercise, which is always good. Potential for GI bleeds. What are your interventions? What are you going to do? How do you know that there is a problem? And especially when they're bleeding, the ulcer has perforated. Okay, what do you do about the hypovolemic shock when they start going into this? Monitoring the vital signs, making sure they have oxygen and fluid. And that's going to go on through there. These are some of your procedures that may have to be done to try to decrease the bleeding during the GI. Surgical, all these end with that. I don't talk about vagotomy. Don't want to get off that. Okay. We're almost there, guys. Hang on in there with me. Trying to stick with the... Okay, that's diabetes. Those are, so we just have 3 more GI. Hello?
Hello?
Okay. Do I still have everybody on the phone?
Yes.
Hello? Okay. 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 Okay, whoever that is, you might want to put them on the, put on your mute button. Joy? Hello?
Hello.
Is that somebody want to put their mute button on? Whoever had my recording going, I can hear myself in the background. Okay. Okay. Okay, this will. Okay, this is a care of patient with malnutrition and obesity. Now, this here is going to just start talking about, you're teaching, and I know I'm summarizing a little bit. You're going to have to think about when you have malnutrition and then you have obesity. So do you see a lot of teaching going on with both of these? Obviously, with malnutrition, we want to make sure that we have the right type of foods, that they're getting the foods that they need, things that are high in protein, because malnourished patients are so at risk for skin breakdown, infection, and so on and so forth. With your obese patient, they're also at risk for infection and other problems. Of course, they're at risk for diabetes. So remember, think about your food pyramid when you start thinking about teaching for patients who are either malnourished or obese. Okay. All right. And this is the malnutrition patient is one of those, the increased protein. They're going to need all their vitamins. What drugs do they need to, not drugs, what supplements are they going to need? What problems are they presenting with? Why are they malnourished? Could this be your patient that's a Parkinson's patient who is not sitting down and eating full meals that we all are eating? This Parkinson patient walking around who has to just you have to get food to them as best you can. You can see a lot of malnourished Parkinson's patients. They could be 300 pounds one day, and when they have Parkinson's and they begin to decline, they're not eating normally. Or you have this person who is malnourished because, first of all, they don't have the money to eat, or they're living on I hear a baby in the background too. Who has their phone? Put it on mute. Whoever has a baby in the background. That's fine. Just put it on mute. You're fine. Okay. Okay. Is that okay, everybody? That was hearing that? Okay. Protein is going to be one of your big things for people who are malnourished because that's going to help rebuild tissues and give the nutrients needed for those tissues that have been malnourished. Okay, so your eating disorders are your anorexic nervosa and your bulimic patients. So can you imagine, can you see them being malnourished because they're purging and making themselves throw up and whatever else because they're at that point of, I want to be skinny. Okay. And an anorexic patient feels like that they're fat all the time. When they're in front of the mirror, they're thinking, I'm too fat. So they'll do this. They'll purge themselves and will not eat. These are patients that end up in the hospital and have tubes placed. They have medical orders from the state that tell us in order to save their lives, this is what we're going to have to do. It can be really, really bad. And of course, it ends up being, I think that who is 6? Who said that? Who's number 6? Who just said that? Madam Sears. Yeah, sometimes I do, girl, but I don't know. I don't know if I would be a really ugly anorexic person, though. I could tell you that one. No, you're fine, Madison. We got to keep it funny. I can't make you laugh because I'm not standing in front of you guys. I know. Anyway, so as we go into this, again, talking about these type of disorders, always getting patient history. What happens? What are the clinical manifestations? What do they look like? What are the psychological assessments? Because, this is a lot of times patients who end up having to go to mental hospitals. This affects everything. Your malnourished patient is affected. The hemoglobin, the hematocrit, the kidneys are going to be affected with your albumin, all of this. The cholesterol levels can be affected. The lymphocytes. What can we do to supplement this patient? And those are some. Now they have Boost. Has anybody ever drank Boost before? Boost? No. Now I tried it and it actually tastes really good. And you make it more of into a shake, and it's actually one of those things that we pretty much, if you take it and put ice with it, kind of almost make it into a smoothie. It tastes pretty good. I can't just drink it straight because I don't like the milky kind of taste, but it's good for a person who's needing the nutrients that they need if they are, active people every day. You're running all the time. These are one of those things. Huh? Who's the liar? Y'all got a personal little me? What are you talking about, Mr. Brooke? Because I know that's you. What are you talking about? Oh, come on. Put a little sugar in it.
You
can do your Ensure. Put some ice cream with it. You can try to make it taste a little bit better. No. I wouldn't tell you don't eat. I'm simply saying that you can use. Y'all are funny. Come on now. The chocolate was the one I tried. All right. I didn't get off into all those other flavors. My goodness. Okay. Anyway, there's your Periactin, Megace, Reglan. A lot of these drugs are going to be used to stimulate the appetite so that these patients desire to eat. Periactin was one of I don't even know. I hope it's still on the market, but that was one that was highly used in the nursing homes. Because a lot of patients, once they became older and Alzheimer's patients, they struggle with not having appetite. Of course, when you have the total enteral nutrition, where these patients end up having to have tubes placed or something of that nature. I have seen where patients have had to have tubes put in, mandated by the state in order for them to continue to live. Scary thing. Okay, that's your PEG tubes and so on and so forth. Okay, bolus feedings down the tubes, continuous feeding, cyclic feeding. These are the type of feedings that's going through that. And so I'm just going to talk about that. Parenteral nutrition. Now, this is your TPNs, where we're giving them lipids, we're giving them vitamins, we're giving them everything that they need through that TPN. The only problem with TPN, you've got to monitor the glucose levels, and then you start thinking about the gallbladder, the liver, and all these other things that can get infected, that can be affected, and after prolonged use of TPN. Okay, obviously, when you're having to get these type of nutrition, you're going to have an imbalance of your electrolytes, your fluid imbalances, and they're always having to be adjusted. Add some here, take some here, in order to keep this patient in balance as much as you can. Okay, now let's talk about obesity. Obesity, we have overweight, obesity, and morbid obese. Severe negative effect on health, usually more than 100% above the ideal body weight. These are those patients who are double the amount that, like, they're supposed to be 130, they're 260, and so on and so forth. So you could be morbid obese depending on your size and age and all those things. All that stuff has to be taken into consideration. When you start thinking about this obese patient, start thinking of all the things that are affected. What starts to be affected? What do you think that an obese patient is at risk for? Yeah, you start thinking about those organs in general, right? Diabetes, yes. Everything's affected, because when we go back, I'm gonna go back to viewer number 6, whoever you are. All of y'all are just so right. Organs, when you start thinking about those organs, as you eat and eat and eat and eat, what happens to the organs? Yeah, they begin to get fat. They become larger. They become fatty tissue, and that begins to affect their functioning. That's correct. They begin to slow down. Great. Who's number 6? Madison. I should know that by now. Okay, and who's 8? Who's number 8? Who's number 8 out there that put CHF? Okay, Roxanne. All right. Going back, let me see what that was real quick. I saw y'all are going so fast. Y'all are doing so good. Organs. Okay. Yeah. And then now we talk about your diabetes. When you look at your diabetes, and you're such at risk because of that high fat that's floating around there, that's in your body, and also that's affecting your tissues. Yes. Your skin breakdown, because you think about these patients who are large patients, rubbing of the skin, those areas that don't get air to them after so long, even when they're lying down, the buildup of dirt in those areas that cannot be reached, skin breakdown. That is right. Joints, pain in the joints, those knee pain. God, you guys are on it. Stroke, definitely, because what do we think about when we think about the strokes, or when we think about a patient having stroke? We start thinking about high blood pressure, right? Those things begin to come into play. Then you have your CHF. Your CHF is definitely a problem, because you're also affecting that heart by increasing that heart. The heart's having to work harder to take care of this larger body, as well as when it's working harder and it begins to um, not have it's not able to work as effectively because there's so much fat around the heart. Increasing that fluid around the heart can cause additional problems. This patient can get very, very sick. Yes, high cholesterol levels, which also can lead to your high blood pressure. These patients are like walking time bombs. Okay. Oh, okay. It doesn't show a number on your end. All right. Yeast infections. Yeah. Spine compression, back pain. Absolutely. Y'all are on it. Definitely. Common complications of obesity. You just named all of these things. Okay. One of the ones I want to make sure you look at is metabolic syndrome. When you think about metabolic syndrome, think hypertension. These are those patients. All of that's so off because they're so large. Obstructive sleep apnea, falling asleep and waking up trying to catch your breath. Yes, you guys really went on and said all of this. Okay. Depression and other mental health. How many people that you know that are really large? Think about these little 13-year-olds that are in high school, or no, what are you in 13? Junior high or wherever you are, being bullied around. Not so much being bullied around, but talked about. You'll find many of them doing the bullying. And a lot of them end up with the mental health because they feel like they have to protect themselves. So you end up with mental health problems, depression, because uh, of that large size. The pressure on the bladder can cause you to sometimes, when you sneeze, have wet your pants or something like that, or having urinary continence because you have these really large people who can't even get out the bed to make it to the bathroom. But again, it's so much effect on those organs. Look at gout, a type of arthritis, which can be affected because of the large person, as well as their uric acid intake. It's because they eat a lot and things that they shouldn't have. Early osteoarthritis, the wound healing is not as fast. Okay. Of course, the etiology, for one thing, we'll look at is diet. One reason why a lot of people are large as they are is because of diet. They're consuming too much or not consuming the right kind of foods. We're deciding we're going to have French fries every morning and for breakfast. Yes, diabetes type 2, you're right. The other thing is physical inactivity, living that sedentary lifestyle, sitting on the couch all day long, eating their favorite chips, as well as drinking all these sodas, a lot of salt intake. Yeah, the couch potato. All right. And it can be familial and genetic factors that can cause the problem as well. But just because Aunt Susie was a huge person, do you need to be a huge person? No, not necessarily. That's why teaching is going to be very, very important. Also, drugs can be a risk depending on what type of drug. Some of those drugs that can cause you to gain weight, a lot of your contraceptive drugs, your steroids and things of that nature can cause that. Okay, so patient history is important, clinical manifestations, and psychological assessment. The goal is that they don't have to have surgery. Okay, that's the hope. Okay. There is definitely diet, nutrition, exercise. Again, this is when you jump in and you're doing as much teaching as you can to try to avoid even having to take drugs, because a patient who starts taking drugs can start affecting other treatments that they're receiving. And of course, behavioral management. A lot of times, all we need to do is what? Learn to eat appropriately and not overindulge. Instead of having a whole hamburger, maybe half a hamburger. Still getting the opportunity, because if you take everything away from a person who loves a certain item, and I can't even talk, a certain item, don't you think for a minute they're going to regress back to that every now and then? I have a problem with drinking soda. I like soda. So instead of taking soda completely out, instead of having a soda a day, maybe a soda every other day, and begin to work your way away from the soda. For those who like French fries like myself, I'm much better now. I was at a point I had to have me some French fries every day. Well, that now I've gotten to a point I can go weeks without French fries. Oh, I have a Me Too out there. Absolutely. But at now I've gotten so much better that I don't have to wake up. I want me some French fries right now. I even have potatoes in there and everything. And I don't sit around and actually eat the potatoes like that. So you just have this a behavioral thing too. Surgical management, and this is when you start getting off into the gastric sleeve, the gastric bypasses, and your lap band and all these other things that people that are doing these days, which is nothing against these things, okay? Because some people 400 and 500 pounds, this is the thing that they have to do to save their lives before they can even start a diet program, because some people are actually too overweight to exercise, if that makes any sense. It's one of those things that they're so overweight that it's dangerous for them to even start trying to exercise, because they could have a massive heart attack. So they almost have to take the weight down to get them to a safe weight in order to start the exercise. Okay, so it starts showing you these gastric restriction or lap band procedures. This is the malabsorption surgery or gastric bypass. Okay, post-operative care, obviously, what do you do? post-operatively to prepare these patients for this surgery. These are things that you need to monitor after the surgery. Remember, you always have pre and post. Okay. Teaching about bariatric surgery and so on and so forth. Oh, we're almost there, guys. I promise. And then we'll go through diabetes real quick. Just trying to see which one of these. Okay. Yeah, okay. So, okay. Okay. This is your inflammatory intestinal disorders, appendicitis, acute inflammation of the variform of the appendix, basically inflammation of the appendix. A lot of times, these are those patients who come to the hospital. Do y'all remember McBurney's point from second level? Remember McBurney's point? That pain, yeah, this stuff is coming back. Stuff is going to make the same sense. And what happens when the patient, okay, what should you be concerned about if the patient all of a sudden is relieved of its pain? Eruption or perforation. Good. All right. It's perforated. So all of a sudden, oh, good, that feel better. Once it's perforated, now we have a medical emergency. So these things are things that is coming back. In order to, first of all, this patient is having appendicitis. If it's just appendicitis without rupture, then a lot of times if we rest them, give them the fluids that they need, put them in position where that they, it's not any pain or strain, semi-Fowler's position, or making sure their pain is under control. We don't want to give any heat, because heat's going to make it worse. We don't want to give laxatives or enemas because that can also make it worse and cause it to rupture. Okay, surgical management obviously is to go in to find out or to remove it. If it's something that could rupture, or if it's inflamed, or they're constantly having problems with it. Most of these patients end up going back and getting removed. Peritonitis is life-threatening. It's basically this is when you have this bleeding out. This patient's going to end up being a bad situation if you don't get this taken care of right away. Talked about peritonitis a little bit earlier, but this is one of those things, the board-like rigid abdomen, that should alert you that peritonitis has occurred. Okay. Okay, you're non-surgical, putting them on antibiotics, NPO status, and all that, repeating itself here. So come out and have it removed. Gastroenteritis is that one that you'll find that we'll use a lot for. We'll talk about when we have a bad stomach, something's upset our stomach. You'll hear us interchange this with gastritis and gastroenteritis. Okay. Increase in frequency and water content in the stools or vomiting as a result of inflammation of the mucous membranes of the stomach and intestinal tract. Somebody with food poisoning. Okay, that's the next one. Food poisoning. This here, you'll see them say, they'll call it gastroenteritis, or you'll say food poisoning. It's one or the other, because it's different. It is different things, although you may have the same type of symptoms, but food poisoning could be actually caused by salmonella or some other type of bacteria, versus gastroenteritis is actually this Campylobacter, Shigella, E. coli, and so on and so forth. Fluid replacement, skin care, drug therapy, and so on and so forth. Now you have inflammatory bowel disease. And this is the disorders of the GI tract with no known etiology. We have no idea what causes it. One of them is ulcerative colitis. And this one here is blood in the stools, loose stools, can get really, really bad when a patient is, when it's inflamed. This is the patient that you'll see more of the bloody stools versus in Crohn's. And here's what it looks like here. Yuck. Assessment is telling you all the things that you're going to be doing, drug therapy and so forth. This is also important for rest. When they're having exacerbation of ulcerative colitis, rest is going to be important. Fluids are going to be important. Watching to make sure that there is no bleeding out or peritonitis occurring here as well. These patients may have to go in and actually have surgery. performed in order to correct this problem. And this is some of the things that they may have to have. Of course, if they have to have an ileostomy, a colectomy, portion of the colectomy removed, then these patients will probably have to have these skin barriers placed for colostomy bags. Okay. Those are what are called. And these are just talking about the colectomy, so on and so forth. Crohn's disease. Okay, inflammatory disease of the small intestines and the colon. And this is the one that starts from the mouth to the anus. This is where Crohn's can occur in any of these areas. People with Crohn's disease, they have those periods of exacerbation. When they have a problem, they go in the hospital usually overnight, feel better, Remicade, come home, and they're back at work the next day. They usually just have to you see how bad that looks? Oh, God. Okay. These are those patients who are at higher risk for fistulas. Okay. Again, it's this non-surgical, surgical management. Okay, diverticulitis disease or diverticular disease or diverticulitis or diverticulosis is the presence of many abnormal pouch-like herniations in the wall of the intestine. But diverticulitis is inflammation of one or more of the diverticuli. These things here can actually open up and cause bleeding. I've seen patients with diverticulitis who have come in with blood coming out of their stool, and it's so horrible. Okay. This here is, again, resting the bowel. And of course, we're going to take care of the hydration by giving them fluids. They're going to get analgesics, anticholinergics to kind of dry them up as best you can. Avoid laxatives and enemas. They don't need any of that right now. NPO, rest. Surgical management. Again, this is where an ostomy may have to be placed. Do I get off into anorectal abscesses? You can read through anorectal abscesses. I'm not going to get off into that. But with the anorectal abscesses, this can occur with your Crohn's disease, though. Also, fistulas can also occur with your anal fistulas are more common in your Crohn's disease. Okay, surgical and colostomy care. Okay, good. Okay. How y'all doing? Y'all hanging in there? Hang on in there. We're almost done here. I think I'm done. Oh, that's diabetes. Am I ready for diabetes yet? I think I have one GI to do. Whew. Okay, you have a lower GI bleed. Irritable bowel syndrome. I think I went these backwards. Oh, no, I did it right, I think. Okay. Irritable bowel. Okay, it's a functional GI disorder. It's this one is gonna be your diarrhea. It's recurrent. This is one of those you could be doing good one day and just feeling really, really bad the next day. And what helps you is go poop it out, basically. And if you can just fall asleep, a lot of times you feel a whole lot better. But usually when you're back up, you're back in the bathroom getting this pooping, basically. You have a lot of abdominal cramping and pain. If you don't go and as you're continuing to have the problem, if you don't go and get it taken care of, a lot of times you start having abdominal distensions. Stress tends to cause this to flare up a lot. And this here, usually when it flare up, this is patients coming to the hospital. This is going to be a lot of teaching, diet. You want to try to teach more about foods that are upsetting and just kind of that can upset and cause them to have these episodes of diarrhea. Of course, controlling their stress, taking their drugs and everything, things that are going to reduce the inflammation. I just said stress management. Herniation. We talked about this type of herniation, basically, depending on what type. This particular one I want to look at, I think you need to understand inguinal hernia. Let's see. Yeah, here's some pictures of one here. These can get really, really weird. I don't want to get off into the indirect and direct. I want you to just understand inguinal hernia. weakness in the abdominal muscle wall through which all segment of the bowel or other abdominal structures protrude through. And they're just the types, but the one I'm looking at more so is the inguinal. Okay, there's the classification of the hernias. They're either reducible, irreducible, or strangulated. Okay, that's going to talk about those. Just talk about the impulse. Y'all can go through that and look at that yourself. Intestinal obstruction. This is when you've heard people say, have you ever heard someone say bowel lock? The bowels, the patient's bowel have locked up. An intestinal obstruction can be a bad situation if it is not corrected as soon as possible, because what you're going to have is all of this feces backed up and it has nowhere to go. So many times, well, I'm going to just go back. I'm going to go backwards, whatever way I need to go in order for it to get out of the body, and it can actually start building up in the bloodstream and can end up killing the patient. Y'all remember these from the intussusception? Remember that?
Mm-hmm.
From second level?
Mm-hmm.
Okay, good. Remember the telescoping backwards into, oh, you don't remember that? Was that said no? I think that's Roxanne. Okay, and then you have this, oh, Maddie. No? Maddie, okay. Y'all are keeping up with the numbers better than me. Okay, with your intussusception, look at this telescoping. And then this bowel, this volvulus, which can be so dangerous. Oh, you said yes. Okay. Twisting right here. Guys, this is bad. This is a situation that this patient's all of a sudden feeling this pain, this backward flow. You can hear loud bowel sounds in one area. Abdominal distension. That's the borgamy, the loud bowel sounds. Tenderness in the abdomen, vomiting. Okay. Okay. Resting, of course, the bowel to try to see if that's going to correct. Otherwise, they may have to go in and actually remove that portion of the bowel that's affected and reconnect, or even put a colostomy on until that bowel has healed. Okay. Polyps. These are what your little polyps look like. These, you start getting worried as far as polyps are concerned. There's a little small growths in the tract. These are the ones a lot of times they're tested for cancer. They'll go and do biopsies on those. And sometimes they'll just leave them alone as long as they're not causing any problems. But these can cause bowel obstruction. Okay, hemorrhoids. I'm sure some of us have experienced them at some point, or if you haven't experienced them, someone you know have experienced hemorrhoids. They can all be irritating, but a lot of times may have to be surgically removed. But this is those drugs of choice, it's your preparation H, your Tux, and things like that to try to help those steroids. Otherwise, not steroids, to help those hemorrhoids. Otherwise, they would have to be removed. Okay, malabsorption syndrome. I was telling you about that earlier. You do need to know the syndrome associated with a variety of disorders and intestinal surgical procedures. Many times when a patient has to have anything removed as far as the intestines are concerned, you have this malabsorption syndrome because when you remove certain portions of, there's somebody who's 4 and it's saying painful. Are you talking about the malabsorption syndrome? Somebody put painful, or were they talk about the hemorrhoids? They probably talk about the hemorrhoids. Okay, with that malabsorption, this is that stinky poo. Every time they go potty, it's stinky because it's not absorbing the normal way because they've lost a portion of their intestines for whatever reason. This is the intervention. Yes, seen in CF patients, right? That is absolutely correct. The intervention is going to be dietary. It could be surgical and non-surgical, and they can use drugs. And with your CF patients, that's when they use give them those enzyme drugs, and I forgot the name of them right off the top of my head, to kind of help with the malabsorption syndrome. However, patients who have truly had the portions of their intestines removed, they will suffer from that. But that's something that, pancreatic enzymes. Thank you. Okay, so that ends that on GI for the moment. You all will be able to go back through there and listen to those, as well as listen to the MP3s or whatever. Let's go through the IBs real quick, and then the clicker questions, and then some notes, and we're going to get off of here. Thank y'all for hanging in there. I'm not sure who's all here, if it's 11 of y'all or 12 of y'all, because I was thinking I wasn't included, but I think I am included in the number. Yeah, so it's only 11 of y'all online. Okay. Diabetes. Okay, this here is just going back to the anatomy and physiology. You know, I'm not about to go through this. This has some notes down here at the bottom. The pancreas we talked about earlier is an exocrine and endocrine gland. Oh, wait a minute. Let me go to my actual deal here. Okay. So going that, you all can go back and look at the previous review, just the anatomy and physiology. I'm not going to do that part, but it's metabolic disorder wherein blood glucose exceeds normal levels. So here we are, a patient comes to the hospital and you haven't eaten anything for 8 hours and you have a blood sugar of greater than 125. That would pose a concern, because each time that we go to the doctor, when I have a checkup, my internist, she will do a blood sugar just to see where you are. Yeah, these are all on eCampus. Yeah, this is where I pulled them from. Yeah. Okay. This here is going to tell you the types. You have type 1. If it's not on there, did y'all not see this one?
No, I didn't see it.
Okay, if this one's not there, then I will. Okay, you have it, viewer number 1. So it's on there somewhere then, because I actually pulled these all off of it's only I only have 1/3 level, so I pulled this from there. If you flat out can't find it, okay, let me know. We can find it. We'll find it for you before we get off. Okay, anyway, this breaks it down for your type 1 and type 2. If I were you, I'd go review that a little. Diabetes. Remember, I was telling you diabetes affects so many areas of the body. I mean, it's the microvascular and the macrovascular. It's just one of those things that if you got diabetes, yeah, I can have an infection. You got diabetes, erectile dysfunction. You got diabetes, hypertension. Diabetes, here's the kidney problems. Diabetes just affects so many areas of the body. What's the most important thing about diabetes that you can teach a patient? Compliance. I mean, that's above all. Compliance. You need to make sure that you take your medication the time that you're supposed to take it. And what are our medications? Some of our medications for diabetes. Insulin. Understanding, because you guys need to understand this part, and this is where I'm kind of going here, and I'm probably so way ahead of this PowerPoint. I'm just talking because it's all out there in my head right now. When you think about the insulins, you need to understand the peaks, okay, and when these medications. So if you have the patient getting ready to take if they take regular insulin, or you need to know those short acting and long acting, that part is going to have to be understood. You need to understand that, because if I'm going in to take this medication, when should I be eating? If I take my shot, I'm taking my shot in the morning at 7 o'clock. When should I get food into my body? Those are things that you need to think about when you're talking about insulin and teaching patients about insulin. Okay. When you start looking at, and I didn't want to go here yet, but when you start looking at that, so that's something to have in your brain as you think about your diabetes. Also, what other drugs could they be on? Glucophage or glipizide, or diabeta or whatever those other ones that are out there. There's so many other type of the insulins that are out there. It's so important to understand those. Also, you need to understand what can be mixed, which ones can be mixed with each other, and which ones cannot. What would you question? Diabetes and ketoacidosis, so DKA. This here can get so bad. You have a patient come in with a 600 sugar level. Would I question things about D50 boluses? Wouldn't I question something like that? Because if I give this patient a D50 bolus and they're in diabetic ketoacidosis, I might as well just be getting ready to plan their funeral. Okay, so look what happens with this. It gives you a nice little concept map. I kind of like the way this breaks this down. So this is something that you can look at, and what it can lead to can be really, really bad. DKA, you need to understand the DKA versus HHS. And here's a nice little chart that'll break that down for you. Okay, here's your vascular issues. Doesn't it affect the eyes? Don't you hear about people talking about they have issues with their eyes? And here's your macrovascular and your microvascular breakdown. And I just used one when I said erectile dysfunction. Look at all of these things. Yes, amputation. Oh, wow, that is just ridiculous of the things that how bad diabetes is on the body. And oh God, I'm glad that that's on there. I couldn't remember if this was on there or not. Okay, metabolic syndrome, something that you definitely want to know. This is that central like obesity. You're going to be concerned majorly with their blood pressure. Their cholesterol level is going to be crazy. And these are going to be your insulin resistant type patients. Very important for you to know and understand. Okay, so then diabetes treatment and insulins. Here's a nice little area telling you about the rapids. So we talk about rapid. When you get this off in there, you know that we need to determine when do we need it. There's your short, intermediate, and your long lasting. A lot of these patients are on one or two of, they're going to be on at least two of these because they want one that takes care of my issue right now. And then we want one that'll last over a period of time. And that's why eating appropriately, knowing when to eat and what type of foods that you need to eat. Very important to understand. Then you start talking about your drugs. These are the classification of those oral drugs that the patient takes. Okay, you got the dawn phenomenon. What happens early in the morning, the Samanji. What happens as they go to bed at night. Why are type 2 diabetics given insulin in the hospital if they aren't on insulin at home? Good questions to think about. I am so dry here. Nutrition's important. We talked about that. Diet, exercise, diabetes, and hypoglycemia. Also, we need to determine a baseline for a patient. If 90 is where you are comfortable, then 90 is where we want to try to keep you. If 150 is your high point and you start having, you have to kind of look at a patient when it comes down to their baselines. What's good for this patient? Some people, I know a person, she functions well when her blood sugar stays 220 all the time. When it gets below that, she just becomes just totally, you can tell that it's too low for her, which is really strange. But again, that's what works for her. Okay, teaching of insulin's rotating site and so on. Diabetes in pediatrics. This is just a chart kind of telling you, let's see. Oh, these are, let me see. What is this one? I think this was just a list of terms here, right? Let me see. I think that's the list of terms. You're taking those terms and you're actually putting them in these areas. Okay, that's what it is. You see that? It's concept grouping is what this is. I think I have it. No, I don't have it backwards. Here are the terms, and then they're broken down to where they go. Does that make sense? Okay, you can go back and look at that. All right, so we're done with that. One more PowerPoint. We're gonna go run through the clicker questions, then we'll talk about the your notes. Okay, so this is gonna go all the way back through the same thing we just talked about. Okay, you think about what happens when there's absence of insulin. These things are going to occur. What are signs and symptoms of diabetes? What do you see? But what do you teach the patient to look for if they feel like that, the polydipsia, you remember those? Polyphagia, polyuria, urinating all the time. Do y'all remember these from way back? Did y'all get this in first semester? Where did y'all get diabetes at? Hello?
We haven't had any diabetes.
Did y'all have it first semester?
No.
Some, a little bit. Isn't this where those polydipsia, polyuria? Okay. All right, maybe not. Okay, it's going to talk about remember HHS and diabetic ketoacidosis. All this is just repeating what we just went through. Macrovascular versus microvascular. There's a chart in the other one. We just talked about metabolic syndrome, right? Assessment. These are all of the different types of screening for diabetes. And then the type of drugs. And then your insulin therapy. Complication of insulin therapy. There's a Don phenomenon, Simonji's. It's just a summary of what we just went through. So you guys can actually look at that because that's going to go basically what we just went through a second ago. So we're done with that. Let's do these quick questions for diabetes. And you got
some of us are so sleepy.
I know. Hang in there. Hang in there. Hang in there. Just a few more minutes. What I want. Okay, then what y'all want me to just post these? HPRS.
Yes, please.
What's HPRS?
That's the class, what you were talking about. We did that in HPRS class. The
okay.
technologies.
Okay, some of y'all are needing to go sleep. Some of you want to go through it. So if you want to stay on here with me, hello? Hello? Y'all still there? I lost my chat.
I'm here.
Oh, okay. Okay. I thought maybe it just fell asleep here. Okay. Y'all are good. Okay. Those of you who need to get off because you're tired, go right ahead. Others that want to stay on here, we can stay on and do these questions. Looks like there's 7. What do you want to do? Okay. Viewer 1 has left. Okay, we're going to keep going then. Okay. Diabetic question. The client is admitted with metabolic, and you could just answer. You guys are too funny. The client is admitted with metabolic acidosis, secondary to diabetic ketoacidosis. Which of the following does the nurse formulate as the priority nursing diagnosis? Okay, you all are picking. Good. I guess y'all probably saw that. Good deal. The nurse is caring for a client with type 1 diabetes mellitus. In preparing to administer insulin, the nurse would complete the following steps in what sequence? Just type it in. What sequence? Okay. It's DBCA. Okay, good. All right. Who the following evaluation data would best lead the nurse to conclude that the client with HHS has demonstrated improvement during the first 24 hours? Okay. Answer is A. So go back and review HHS. You guys get a chance. The nurse is caring for a client who is taking 4 units of regular insulin and 30 units of NPH insulin at 8 o'clock. The nurse keeps which of the following in mind regarding this regimen? Select all that apply. Y'all answer me. Okay, select all that apply. The nurse keeps which of the following in mind regarding his regimen? Yeah, y'all are getting pretty sleepy on me over there. Okay, A, B, and D would be the correct answer on that. A nurse is caring for a client admitted to the emergency room with DKA. In the acute phase, the priority nursing action is to prepare to do what? Okay. He is correct. Good job. I think we're just about done. A client with type 2 diabetes has a blood glucose level higher than 600 and is complaining of polydipsia, polyuria, weight loss, and weakness. A nurse reviews a physician's order documentation and would expect to know which of the following diagnoses. The answer is D. Let's go back and just look at both of those. A nurse is caring for a client with type 1 diabetes. Which client complaint would alert the nurse to the presence of possible hypoglycemic reaction? Okay, good. A. All right, good. Y'all hung in there. What I'll do is go through these few notes or whatever next week, as well as cover GI. I'm sorry, GU. That will be the only thing that we have to cover is GU. We'll do a case study, and then we'll go through and just make sure we've covered everything in regards to, the terms and things of that nature. So, try to work on the next case study, do the terms, and come prepared for GU next week. And thank you all for joining me on this tonight. Does anybody have any questions other than being quite tired?
How about Thursday? What are we doing on Thursday? This Thursday?
That's what I just said.
Oh, okay.
GU.
I thought you said next week.
Thursday. I'm sorry. Thursday. No, Thursday is going to be 2 to 4. Everything. We're only going to do our regular 2 hours. We just did over 2 hours part. Okay. Good night, everybody.
Okay, thank you.
Bye-bye.
Okay.
Phew. Oh, I'm tired.